Okay, now for the audience here and for our audience live, worldwide, welcome back to CFRI's 26th National Cystic Fibrosis Education Conference, coming live to you from the Sofitel San Francisco Bay in California. This is the second session that we are streaming on Ustream and CFRI Live. Welcome to our online attendees. Many of us have questions about the effect of Obamacare, or the Affordable Care Act, and what effect that will have on our health care insurance. We thought it was a good idea to learn about what is currently known from a local expert with more than 30 years of experience in government. Our moderator today is Francine Bion. Francine has been a volunteer at CFRI for over 25 years. She became active with CFRI after learning that one of her nieces was born with CF. Francine has served on the CFRI Board of Directors, initiated our website, chaired the newsletter and website committees, and has helped plan an annual golf tournament to benefit CFRI, which I may remind you is tomorrow. So see me for details. She's also been on the conference committee for 4 years and is also a Mother's Day tea sender. Our speaker today is Sherri Sager. She is the Chief Government and Community Relations Officer for Lucile Packard Children's Hospital in Palo Alto. Ms. Sager has worked as staff for elected officials on all levels of government, managed political campaigns, and volunteered on city and county task force and commissions. In 2006, Sherri led the successful legislative effort to add 2 disorders, CF and biotinidase deficiency, to the state's newborn screening program, which was included as part of the 2006-07 budget trailer bill. Sherri has a BS in political science from Santa Clara University and an MPA from San Jose State University. If you're ready, Francine, audience, please welcome our speaker and moderator, and please begin. Thank you.
Thank you. Good morning, everyone. Our conference committee would be remiss if we didn't have a topic of discussion on the Obamacare or Affordable Care Act that will be hitting us very soon. October 1st, we will begin to have sign-ups here in California. I'm not so sure if that's true nationwide, but it's a very timely subject. And our format today will be a moderated discussion, so it will be a kind of give and take. And I will start by asking, we will start first with Sherri's presentation, which will go on for about 10 to 15 minutes. And then I will be asking prepared questions. And then you, as the audience members, will also have a chance to take part by filling out forms or little cards that are they being distributed now? Oh, they're already there. Wonderful. Okay. That's where you can write any number of questions. The MC will be collecting them, collating them, and then handing them to me at the appropriate time. So that's basically our format. So we're delighted to have you today, Sherri. Move this a little bit. She told me over the phone when we spoke that when she was 18, the ability for 18-year-olds to vote happened that same year, and she was completely hooked on the political process from that point. So she's worked on numerous campaigns, political campaigns over the years, and her volunteer work took her to youth organizations like Big Brother, Big Sister. So it seemed a perfect fit for her to join the Lucile Packard Children's Hospital and to be their Chief Government Relations Officer. So we'll hear from her now, and she'll speak on the legislation that's coming to us, and if she will focus on how it will affect people with chronic health conditions, such as CF. So here today is Sherri.
Thank you. I wanted to put this in some context before we started on the moderated questions, and I'm going to start with an editorial comment. Anytime you pass legislation that's as comprehensive as healthcare reform is, it's never completely right the first time. It's just too complicated. The editorial comment is, we are now in a political environment that doesn't allow for necessary changes to occur. Republicans are afraid to offer up amendments because if they do, somebody in their party will tell them that they're a sellout and will launch primary opponents against them. If you're a Democrat, you don't want to offer an amendment because then somebody will say, see, we told you there was a flaw in that and we should just repeal it. And so we're in this quandary where everybody knows that there's some things that aren't quite right, but you never know what those are until you actually start to implement it. And so it's my fervent wish and hope that over the next year or so, we'll see some of the partisanship start lessening on this issue to allow us to make the kinds of changes that will help this to achieve the goals. I also wanted to just put it in context because it's gotten labeled for good or for bad as Obamacare. Not only is he not the first president to offer health care reform, this has been a bipartisan effort. And so I didn't want to go all the way back. I just went back to 1912, so 100 years. So we've got Teddy Roosevelt campaigning on health care reform. We have President Franklin Roosevelt when Social Security came in first, and then he tried health care reform. Truman trying to create national insurance program. President Kennedy campaigned on it. Lyndon Johnson convinced Congress to pass both Medicare and Medicaid. And if you tell people that we would, what would we do if those two programs didn't exist, I don't think anyone has any idea of how bad it would be. The legislation that was implemented is almost identical to what President Nixon introduced in 1974, and I don't think he would ever be mistaken as a liberal Democrat. President Carter pushed a mandatory national health plan. Ronald Reagan, the darling of conservatives, signed COBRA to allow people to continue with health insurance when they lost their job. President Clinton, as we all know, tried to develop a universal health care plan. My other disclaimer, I am not sick, I have allergies. So sometimes when I talk, I cough for a few minutes, so I am not contagious. President Clinton first tried to do comprehensive health care reform. That didn't work, and then he came back and said, we've got to do something at least for kids. And again, I don't think there's anyone on either side of the aisle that wouldn't agree that the state children's health insurance program hasn't been successful in getting kids health care and health care early. President George Bush added prescription coverage to Medicare. And then in 2010, we've got the Affordable Care Act. So I just wanted to put it into a context that this isn't just something that President Obama dreamed up and said, I'm going to impose this. He really based it on a long history. And in fact, a lot of what's in Affordable Care Act was what Governor Schwarzenegger tried to pass in California 2 years previously. But why now? Why did this happen in 2010? What was the nexus and the catalyst? And it was that the costs for care kept increasing, not only for us as individuals, but us as a nation. And you can see the per capita expenditures for the US is dramatically higher than any place else. And one of the comments I hear all the time is, oh, but we have the best health care in the US. I'd like to say I agree with that, but I don't want to lie to you. We have very good health care in parts of our country, and we do very good research, but we're not the only ones, and there are other places that do a better job. The other why now is the number of uninsured was increasing. And though the percentage has gone down, that's because we have more people. The numbers keep going up. And in California, we had 15% of all the uninsured in the country were here in California. That's disproportionate. We're about 12% of the population, but yet we were 15% of the uninsured. And so 49% of people had their insurance from their employers, but look at the number that are getting it from Medicare and Medicaid. Almost a third, 29%. So if those two programs didn't exist, more than half of our residents in our country potentially could be uninsured. And then just sort of the difference between the non-elderly, because you take the Medicare program out. So I always want to start with, we've got a few government programs already that are health insurance programs. So when you hear people say, well, I don't want the government messing around in my health insurance, they already are. Medicare is probably the best program. And again, when people say, I don't want a single payer system, and I'm not necessarily advocating for a single payer system, but Medicare is an example of a single payer system where you have choice of who your physicians are, which program you're on, which insurance product, but the bottom line is the dollars are coming from the federal government to pay for it. Medicaid, which is the largest insurance program in the US, is a state-federal partnership, which is both a blessing and a curse. It's a curse because it means it's different in all 50 states, plus the District of Columbia and Puerto Rico. So we have 52 different programs. It covers more than 60 million low-income individuals, families, children, the elderly, the disabled. Eligibility rules are different for every state. Benefits differ by every state. But there are a core of benefits that are available in every state. The Affordable Care Act will expand those options for community-based care as an option to nursing homes. As people age, a lot of folks don't want to go into a nursing home, don't feel that they need it, but they need some additional help. This will help to provide some of those additional pieces. Again, most of us know the basics of Medicare. It's for people aged 65 and older, or if you're under 65 with certain disabilities. We always laugh, we're a children's hospital, we shouldn't have any Medicare, but we have kids who have end-stage renal disease. And end-stage renal disease is covered by Medicare no matter what age. There are 4 parts: inpatient care, doctors or preventative service, usage of private companies for benefit coverage, prescription drugs. All the same elements that are in the Affordable Care Act. The Affordable Care Act was about 3,000 pages. Originally, they wanted to keep it as simple as possible and let the details be filled in by the experts. That was impossible to do. And I'm actually going to do a little divergence from the slide in that you may have been reading lately that there was an issue around federal or employees of members of Congress. And that was a poison pill that was put in by Senator Grassley, who said, well, if we put this in that congressional employees have to be covered by the Affordable Care Act, that'll cause members to vote against it because they won't want their employees to do that. Well, it didn't do that. But the problem is there's language in the Affordable Care Act that says if you have employer-based coverage, you can't be part of the Affordable Care Act, and it doesn't provide for your employer to pay your premium and to pay your health care if you're in the Affordable Care Act. So staff or members of Congress were caught in this bind that they currently have health care benefits, but they were going to lose those health care benefits, but Congress couldn't pay for them. So they've made a regulation that makes an exception for congressional employees. So they will be part of the health care exchanges, but the federal government can continue to pay their premiums. There are more than 90 provisions that have to be implemented in total, and most of them are fairly complex. They focus on expansion of coverage, controlling healthcare costs, improving healthcare delivery systems, consumer protections, wellness and prevention, long-term care, workforce development. Probably the best known on the expansion of coverage is Medicaid. But that was taken to court, and I will come to that in a second. Short-term, who won? Immediately after passage, children with pre-existing conditions were all of a sudden that they were no longer allowed to be discriminated upon because of their pre-existing conditions. Young adults were able to remain on their parents' policy. So it now is up to 26 if they were not covered by an employer-based insurance. So if they were working at like a high-tech company that offered health insurance, they couldn't say, well, I'm not going to take your health insurance, I'm going to stay on my parents'. But if they were working in a small business that didn't offer health insurance, they could stay on their parents' policy. And the uninsured who are going to get access to care, and we all won because it says that preventative care and trying to stay well can no longer have copays. So that trying to keep us all healthy is a positive thing. Long term, if we can reduce the costs of health care in this country, both for us individually and as a nation, all of us will have won. We will have reduced the amount of money going to health care. We should have better outcomes, again, for all of us, because one of the things that they're looking at is having payment structures based on quality and value and not just the amount of tests that you take. So you're also going to see a huge shift to try to move more health care out of the hospital setting and into community and outpatient setting, which just that alone can be a reduction in cost. And then all individuals who have a pre-existing condition. Although I don't think of it as a pre-existing condition, I do have mild asthma. So if I weren't covered by my employer and I was unemployed, I would have to pay a higher premium. Now or I might even not be able to find it. I don't think of it as a pre-existing condition because frankly it doesn't stop me from doing anything I want or need to do. But most of us have pre-existing conditions of some, when you get to some age, of some kind. The provisions expand the public programs, most notably Medicaid. It creates state health insurance exchanges. And I'm going to use California as an example because it's farther along than any other state. But for those states that have chosen not to do their own health insurance exchange, there will be a federal health insurance exchange. There are changes to private insurance. There are individual mandates. There are employer requirements. And there's an emphasis on prevention and wellness. And the provisions all fall under one of these buckets. When the Supreme Court heard the case, there were two main provisions that they discussed: the individual mandate and the Medicaid expansion. The court decision said the individual mandate was constitutional, that the government can say you have to have health insurance, you have to pay for it. But they said states could choose to not accept the Medicaid expansion and the Medicaid funds, but still not lose the other funds and the other potential programs. So it wasn't an all or nothing. Originally, Congress had envisioned that the Medicaid expansion is a part of reducing the number of uninsured. And for the first 5 years, the federal government picks up 100% of the costs of the newly covered. So if you were, or actually the newly eligible. So if you were a child of low income and already eligible, you just hadn't signed up, it would still be the existing formula. But if you were a young adult, about 30, who had never been eligible before, the full cost for the first 5 years is by the federal government, and thereafter the federal government will pick up 90% of the cost. So my editorial comment, it's actually a good deal for the states because if folks aren't covered by Medicaid, get sick, they end up in the emergency room as uninsured, that's a state's responsibility to pick up those costs. The consumer protections that go into place as of January 1 is to prohibit discrimination due to pre-existing conditions or gender for everyone. It's the elimination of the annual limits on insurance coverage. And then I know this is one that's of interest to all of you, is ensuring coverage for individuals participating in clinical trials. So there's still an emphasis on we need to do research, we need to come up with best practices, and if you're participating in a clinical trial, it should not impact your ability to participate in either the health exchange or if you have existing insurance. The other benefit is that it will improve the integration between hospitals and physicians. We're no longer really separate entities. We have to work together to come up with the best care plan for patients. It will increase access to affordable care, and physicians are going to be paid based on the value they provide and not the volume. And you've already seen a number of pilot programs in the Medicare system that are looking at this. They just finished a pilot of 26 affordable care organizations. Palo Alto Medical Foundation locally was part of that, where they saw that did reduce costs. It also reduced the number of unneeded or duplicative tests. One of the things about improving the integration between hospitals and physicians will do is it will reduce the redundancy in tests. Because right now, you might have a test done by your physician. You then get hospitalized. The physician in the hospital may not have access to those test results or may not know the physician who did it and may not feel as comfortable, and they'll run them again. Well, if you're more integrated, we can reduce that redundancy. And again, as I mentioned, we're going to be moving patients to the outpatient setting, which we think is a better system for everyone. The problem is we haven't moved the payment system yet. We're changing the delivery system, and now we'll have to talk about how we change the payment structure, because we don't want to decimate hospitals to the point where they go away, because we still need them. We just don't need them for some of the things that they're doing today. The health exchanges, which sounds like it's this word, and you look and you think, what are they talking about? It's government ease for a marketplace. So it's one place where you could see all of the plans, all of what they offer, all of what the costs will be, and then make your choice. So in California, we have what's called Covered California. Other states have their own version. The federal government will have their version of the health exchange. The health exchange is responsible for contracting with the different healthcare plans, having a set of standardized benefits, figuring out a cost sharing, and then the federal government provided for subsidies that will be available based on income. In California, we talk about 3 tiers of plan: gold, silver, and platinum, silver, gold, and platinum. And then there's also technically a bronze, which is a catastrophic, that's only available to a small portion of folks. The federal law also said, here are essential health benefits that when you figure out which health plans are participating in your program, all of them have to have programs and coverage for these basic benefits: ambulatory patient services, and including blood tests, x-rays, vaccinations, emergency services, hospitalization, maternity and newborn care. You wouldn't think that maternity would be controversial. It's hugely controversial. There are a lot of health plans that don't want to cover maternity. Mental health and substance use disorders, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, prevention and wellness services, chronic disease management, and pediatric services, including dental and vision care. Every plan has to have a way to cover all of those benefits. And that's where I'm going to stop for right now, and I'm happy to answer questions.
Hey, thank you. Sorry. I think I should have had this on the other side. Okay. Work with it. Okay. Thank you so much, Sherri. First off, we'll start with the question of, must we buy health care insurance?
Yes.
Okay. And
That's the individual mandate. The individual mandate says that we do need to all purchase health insurance, and there are penalties if you choose not to.
yes, what are some of those penalties
Okay,
and
this is where I have to
exemptions?
pull the cheat sheets out.
Okay. Absolutely.
Oh, yeah, I know, and this is only some of it. And I probably won't find it quickly, but what it's a percentage of your income that has to be paid. And there's a minimum dollar amount, and it says, for example, $95 or 1%, whichever is greater. So they're trying to make it, well, it's for 2 reasons. One, so that it hurts, and so people do choose to get insurance. And 2, that will help to pay for the subsidies that they'll provide for folks who are low income.
Right. But if you have private insurance through your employer, you don't need to purchase
Nope,
into
if
this
you-
plan.
They're actually encouraging you to keep your private insurance. They're encouraging employers to continue to provide health insurance and are actually trying to find ways for other employers who haven't to step up to the plate and provide it. So there are penalties for them as well if they've gone from providing health insurance to no longer providing it.
And will this act impact any charges that the employer may give to the employee for the health insurance? I mean, will the rates change as a result of this?
It doesn't impact what the premium copays are that you would pay. Rates are already going up based on things other than this legislation. So I would assume that we'd all, the hope is that what we're going to do is reduce the growth rate in healthcare costs. So it has been, for years, it was significantly higher than inflation. It was double digit. And so the idea is to bring healthcare, the growth in healthcare costs down to under 5%, which is a more sustainable number and would start reducing our overall costs.
Okay. Let's discuss some scenarios. I'm sure some of you have some thoughts about your own situation. My child has CF and we receive Medicaid. How will the Affordable Care Act change my coverage or affect it?
Won't change your coverage at all. If you're eligible for Medicaid now or your child's eligible for Medicaid now, they will continue to be eligible for Medicaid.
And is that also true for adults?
Well, actually, there may be some adults who currently are not eligible for Medicaid but may become eligible. So that's part of where there could be expansion. So a lot of the biggest growth in the Medicaid program will come from adults who were previously not eligible.
Okay. And here's the situation. I'm an adult with CF. I've had a job but had to quit work due to exacerbations. Then I went on disability. My condition improved and I went back to work, and then another exacerbation and had to quit. How will insurance change for me coming January?
Well, you should be, when you're out of work, you should have the opportunity to choose whether to do COBRA through your employer or to go to the health exchange. And the health exchange should be able to provide you coverage at a less costly than COBRA sometimes is. So, but that would be something you would need to evaluate what your company was paying and what the COBRA payment would be and what's available. And I think, I can't remember whether it's on one of the questions, but the different tiers, you really want to look at those, and it's not so much as to say, oh, well, I want to pay. You need to decide how much you want or can afford to pay, excuse me, in premiums, as well as copays, because the more you pay, the more, in terms of your premiums, the more coverage you have. So you might choose to pay a smaller premium, but then you're responsible for more costs on the other end. So it's really important to look at each of the plans, look at your own life, your family's life, and determine what their needs are in terms of determining which plan makes the most sense for you.
So I imagine even today, before the Affordable Care Act, there's some insurance companies that don't cover certain procedures. What happens now with the Affordable Care Act? Is that...
Well, it's one of those areas we're going to find out. We think it should cover, but there are still health insurance plans that are enacting this, and so my guess is we're going to be doing some discussion on some of this stuff and learning as we go, and this may well be one of those areas that once we put this into place, we come back and have to fix. The other piece I wanted to mention on the different tiers is depending on where you live can make a difference in what your premium is. So California is divided into 4 regions for figuring, and that will be true elsewhere in other parts of the country. You know, we live in the Bay Area, the cost of health care and the overall cost of living is different than it is in the Central Valley or in Southern California. And so we're broken into regions, which can make a difference in terms of what you pay in terms of premiums.
Right. Okay, and I'm sure many of us are interested in financial help that is available if you do qualify for it.
If you're up to 400% of the federal poverty level, which is, should be doing, I looked at it. What are those numbers? I look at it and I forget as soon as I look at it. But it's roughly about $40,000 a year for a family of 4.
30, here it is.
Oh,
I think that third paragraph.
Third paragraph.
Is that about right?
31,000, just over 31,000 for a family of 4. You can get tax credits. And then up to 250% of the federal poverty level, there is a subsidy that will actually help to pay your premium cost. So they're trying to make this where it's not going to bankrupt you to pay for your insurance. Oh, that's even worse with the microphone.
Yes, it is. We discovered that yesterday.
I
Okay.
apologize to those of you who are hearing this online.
Okay. All right. And we have an economic crisis here in California, and how will the states and the federal government pay for this? It's a lot of money we're looking at.
It's a lot of money. Ultimately, it's a lot of cost shifting. It's moving dollars that we're already spending on health care into trying to prevent onsets, to do better screenings, better diagnostics, trying to move it out of the inpatient setting into the outpatient setting. But there are some fees. There are fees that those of us in the hospital industry will pay, in the medical device industry, and that employers will pay if they are participating, that if we don't participate as individuals, that we'll pay. And all of those fees are part of what will help to cover the cost. And it's a delicate balance. It's why, again, you've probably read in the paper that the administration has heard some of the concern from small business owners that it really isn't ready that the exchange isn't really ready for small businesses. So he's delayed that a year, but that's delayed some of the dollars that were expected to come in to pay. The medical device industry has gone back to Congress and said, we can't afford to pay these fees. It will be a problem. And so there's an effort to eliminate the fee on medical devices. And I've challenged members of Congress who've said that to say, okay, you say you support the Affordable Care Act, you want to take that fee out. What are you going to replace that with? Because it's a delicate balance. And so the response was, this was a candidate, and that I asked at a candidates forum, and he just kind of looked at me. When he got elected, 6 months later, I saw him, and he said, "You're the person who asked me about what I was going to do about the medical device fee if I took it out, what I was going to replace." I've never forgotten that question. So he's working on trying to come up with an answer. So it's part of our responsibility to ask those questions. And it's also part of our responsibility to tell legislators that it's okay to work together and to try to fix some of these issues. Because if they think that people won't support them if they work together, or that they have to take, just one, they're never going to work together. They have to hear back from people in their home areas that we want them to work together.
Okay, we've got lots of your questions. I'll begin with these. This one is about the metal levels. I've heard of restrictions on getting so-called platinum health insurance, which will likely be the best insurance for CF care. What are those restrictions, and any tips on choosing the best plan for my CF self?
The restrictions are actually on the employer on that. So employers who have what are considered platinum have to pay an additional fee to help subsidize it. So what you're seeing is that some employers are reducing what they're offering or increasing co-pays and premiums that their employees have to pay. It's not so much what's coming into the health exchange. But there is, in the Platinum, what it will cost, the maximum out-of-pocket for one is $4,000, and the maximum out-of-pocket for a family is $8,000. And, but some of the coverage, I'm trying to read it with this light, sorry. Some of the coverage is that there's some copays that are higher, there's some that are lower. Most of them are lower, but overall you are going to pay a slightly higher premium.
Is that a month or
A
a year?
year.
Okay.
It should be a year.
Okay. All right, what about the limitation on the costs for the individual policy? So far, our insurance rate has been increased 12 to 15% yearly.
Well, that's going to be controlled by the health exchange. And I can tell you in their first round of the health plans, they put an upper limit, and the health plans that bid on participating had to come in underneath that. So that will be one of the things that that marketplace will do, is to try to keep those costs down, so that that we don't see the double-digit increases.
Right, so there are insurance companies that had to bid to be a part of the exchange. And so you'll see some of the major insurance companies, am I right? And then some that you might have seen in the marketplace will not be there. And that's just an FYI, and that was really based on their ability to keep costs down.
Their ability to keep costs down, their ability to have an appropriate network, to make sure that they had enough providers in their network that they could actually provide the care that they were going to be contracting to provide.
Right. Okay. I am.
And in a minute, when we're through,
Yeah.
we will put a list of websites that you can go for more information.
Okay. I am a stay-at-home single CF mother and receive minimal child support. How is that calculated? What she would have to
Yeah.
pay or
The,
receive?
I'm not sure I know exactly how that will be calculated, but what I do know is that they're putting in place a system of navigators and experts that could actually work with you individually to walk you through and to help you figure that out. Sorry. If I'd stopped talking, I'd stop coughing.
Okay. If we shift towards paying physicians based on value rather than volume, how do we ensure quality care is measured and assessed accurately?
Well, one of the things that Medicare has been paying for years are quality measurements on adult health care. And so there are some pretty well-documented best practices and quality guidelines. One of the things we've been able to do with the Affordable Care Act is start developing them for pediatrics. Because right now, what they consider quality guidelines for pediatrics are things like, have they had their immunizations? Have they reached their height and weight measurements? Oh, yes, and have they had their eyes examined? Those aren't really, quality measurements. There is a pediatric collaborative that's called the Ohio Collaborative that's made up of more than 50 hospitals with their top quality physicians there that are working across the country on developing best practices. And so that's how we're going to start being able to have those quality measurements. And then the insurance companies, the plans will say, if you aren't following these protocols, we're not paying you.
Okay. Will the integration of hospitals and physicians increase or reduce the authority or speed of decisions regarding a procedure or test? That's a good one.
Okay. I'm hoping, against all hope, that it will actually increase the speed because people will have developed better relationships and be able to make decisions quicker. One of the things that we're working on in the children's hospital world is looking at the Medicaid population and saying to the federal government, you need to do an overall designation because these kids cross lines, state lines all the time. and it's a delay in care when we have to individually negotiate a contract with a health plan or the state in order to take care of that child. But if we don't, then we don't get paid. If we take a child and say, this child, it's emergent, we need to take care of this, but we haven't gotten authorization, the state can come back and say, oh, well, we're going to only pay you a minimal amount, or the health plan, because we didn't agree to that. Well, there may not have been anybody there on a Friday night at midnight to agree, but that's when that child needs the care. So we're looking at trying to create some systems. And we recently met with Senator Wyden from Oregon. And he looked at what we put together, and he said, that's exactly what I want to do for the senior population. So if we can get this and see how it works for kids, then maybe we can do it for seniors. So it's all of it is based on being able to have physicians and hospitals talking together, talking quicker, being able to make decisions that are patient-based sooner rather than later.
Okay. Yeah, you mentioned state to state. This was a question about if you're changing residency from one state to another, or I would assume if you're in a state that you don't live in and you need the care, what happens?
Right now, it's hard to say because, some states are going to have their own health exchanges. Some are going to be part of the federal one. It would probably be similar to what we have to do with Medicaid and do individual negotiations. And so it's, I hope that over time it will actually improve, but I think it will take some time to get there.
Well, they should have panels of parents and people with chronic conditions to be on to evaluate some of these things, because we have the scenarios. We live the scenarios.
You absolutely do. And excuse me. And it's absolutely invaluable. It's really funny when we were trying to get approval to expand the hospital, and we had some officials say, well, don't bring us all of those sick kids, to tug at our heartstrings. This is a land use issue. And we're like, no, it's an issue about getting access to care when you need it.
All right, talk for a minute about preventative care. Are there co-pays?
Excuse me.
And
there are no co-pays for preventative care.
Does it have a good definition so we know what that means?
Yes.
Okay.
It may take me a moment to find that one. And I actually had this in an order.
Would you like me to go on to another question?
Eliminate cost sharing of cover preventative services. Yes, go on to another one, because I can't quickly see it. I know it includes some basic things like annual exams, mammograms, and there's a few basic things that it includes.
Right. We can come back to that if we have time. What will happen to programs like state-run programs like GHPP here in California?
We're not sure. The state for some time has been trying to fold CCS into Medi-Cal managed care, and we've been fighting that, saying that Medi-Cal managed care doesn't have the same standards and the same protections for kids who are covered by CCS. The same could be true for GHP, but we're still working with the state on terms of how that's going to, we're trying to keep them carved out as long as we can until we can have assurances that there will be the same standards of care, and that includes the same types of panel physicians, so that what we keep telling them is you can't do any willing provider. It doesn't work well. And we actually have some data that researchers at Stanford have done on the CCS program that have shown that kids that go into a regional CCS center, which are covered by Medicaid, actually do better than kids on private insurance because they don't necessarily get to the right centers. And they end up sometimes with adult physicians taking care of them.
Regarding pre-authorization,
Mm-hmm.
is there reform or elimination of this?
I don't recall seeing anything about that, so the answer is I don't know.
Okay. I use the California Exchange website, and my premium is more than we can afford. Is there any additional assistance?
There should be. So as they start putting the navigators, getting them trained, you need to go back and look at the financial, the options for getting some financial counseling. They should be able to work something out.
Okay, we will now talk about someone's scenario of what this will be like for us as a country. I've heard it being compared to socialized medicine, like in the UK. Is it going to be? I've heard people have to wait forever to get in. Once an appointment, you wait forever and care is unacceptable. I'm very concerned it will gravely affect my daughter's overall health and prognosis. Please help me understand.
I don't, until we actually implement it, we don't know exactly what it will do. But based on the research we've done and what we've looked at, I don't believe that that scenario will be the case. We are not looking at rationing healthcare. And when you have a lot of those long lines and waits, sometimes that's because care has been rationed. What could be problematic is that we are going to have an influx of millions of people who will now have access to care, and we may not have enough existing providers so that there will be, in some areas of the country, there may be longer waits than we have today. But I think that one of the things we're all trying to work on is how do we compensate for that. We know, for example, when primary care physicians have a child with special health care needs, a primary care visit takes longer than it does for a healthier child. And so how do we then make sure that they have the resources they need to be able to do those visits in a timely way and give that child with special health care needs the attention and the time that they need. So those are all part of how the delivery system is going to change in response. And you know what? I think at the beginning that there will be some stumbles, and there will be, the person who yells the loudest will be able to move up to the front of the line. But I think we're going to learn from it. So I don't think it's going to be a long term that we'll have that. But I think that there are some growing pains.
Yeah, that's true. Okay, this is something I think a lot of us are concerned about. Who will be making the decisions on what treatments are approved or denied? Right now, you go to your healthcare provider and there's a kind of joke about it. Somebody's sitting at a desk and deciding, oh, well, this doesn't seem to fit into our guidelines.
Unfortunately, that's not going to change. So we're going to keep being the advocates on the other side. And again, the biggest frustration, and I'm sure all of you have it, is that you have someone who's making that decision for the health plans that have no knowledge of the diagnosis. We face that all the time with having adult physicians making decisions on what kind of specialized care children need. So we're still going to have to push back on those. But that system's not changing.
Okay, and then non-U.S. citizens, will they be required to hold to the individual mandate in purchasing insurance?
Legally documented non-U.S. citizens, yes. If they're not legally documented, they are not covered by the Affordable Care Act.
Good, that's good to know. All right, let's see. Can you explain the difference between large employer self-pay and standard real health insurance? Does large company have contracted costs. And do you understand the question?
I understand the question. I don't know enough about how large employer self-pay works, other than to know that that's what we have. And so a lot of large employers then contract with different health plans. And so, but basically, they contract with health plans to do the underwriting, but the large employer is responsible for the costs of the plan and the costs of care for their employees. So, but I don't know enough about that to
Okay.
answer that one.
All right. Will age be a factor in being able to access care, especially for lung transplants or bowel surgery?
There's nothing in anything that I've read that has age in there other than that, you know, kids up to 26 can be on the insurance policies, but there's nothing to limit. There's no change in existing law is really what it.
I don't know if the questioner was wondering about that recent, very highly public case about the lung transplant for the young girl.
That is separate from the Affordable Care Act. That is not covered by the Affordable Care Act, and that will ultimately, in that case, be a decision that UNOS will make.
UNOS, and that is?
United Network of Organ Sharing. And they're the ones who set the rules and the standards.
Okay.
So this particular case that went through court bypassed that, but the direction was for UNOS to go back and look at that.
All right, my family has coverage through COBRA and now through HIPAA, which is extraordinarily expensive. What will our options be here in California?
Your options will be to go to the health exchange, look at the marketplace, look at the different plans that are offered in the area you live, and be able to do that as a comparison with what you currently have. And if you could find, hopefully you'll be able to find something less expensive, or that potentially, based on what the costs are, that there may be some tax credits or subsidies available.
Okay, and then we have one, how many? Three minutes or three questions? Okay, all right, great. All right, these two are very similar. I'm currently employed and my company offers private insurance. However, I am unable to afford the monthly premiums. Can I decline and use the Affordable Care Act if it will be cheaper?
No. No. You would be taxed. You would have a penalty, as would your employer.
And here's similar, can you be dual coveraged with private insurance and have ACA to pay for things that private insurance doesn't?
I haven't seen anything that says you can.
That you can't?
Yeah, I have not seen anything that says that you could. So I think that's an unknown area so far.
Okay. All right, we have one more question. Which one will this be? Is there any pressing question that anyone has? Or shall I just...
not, then
Oh, here we go. Here's one.
About providers, are they going to have to take the health care? Will the providers have to see the patients with these new insurances?
The providers will it will be like any other health insurance. So if they have a contract to take Blue Cross, Blue Shield, and you come in with a Blue Cross Blue Shield, they're going to take it. They're not going to know whether it's through the health exchange or whether it's through an employer. So if they take Blue Cross, they would take it.
So all the insurances in the exchange are already in existence?
They are in California.
Yeah.
They're all existing health plans in California. But not every health plan in California has opted to belong to the exchange. And then if you'll just hit the down button, the down arrow, and there's a list of resources which are absolutely incredible in terms of learning more information. I've given you the examples for the Kaiser Family Foundation, which does the most up-to-date research and reports on this. They make all of their information available free of charge. Same thing with the California Healthcare Foundation. The Health and Human Services Agency is the federal agency responsible for the implementation. And then I gave as examples for California, Covered California, which is the consumer-friendly website, and then the Health Exchange, which is less consumer-friendly.
Thank goodness for cell phones. Look at it.
Okay, this concludes our conversation about the Affordable Care Act. However, Ms. Sager will be back at 2 o'clock, so you can think about some questions over lunch and come back, and we'll do this all again.
Thank you, Gary.
So let's thank Francine, Bion, and Ms. Sager.
Good job. Good job.
So to those of you online, thank you for joining us today. Both of our streamed sessions will be on our website, www.cfri.org, soon. Check there for future CFRI Live online education sessions. Our monthly CF Discovery Series will resume on Tuesday, September 10th. So just a couple of very quick announcements, and we're going to break for lunch. Checkout reminder. We've mentioned it 2 or 3 times. Make sure you check out by 1 o'clock today. Luggage must be out of your rooms. Bidding for the silent auction items will close in 15 minutes. I walked by that room.